good evening, everyone. I'm Dr. Amit Gupta on behalf of Team USC. Welcome you all for today's CME India webinar on diabetic food and selection of antimicrobial in this session. So to set the context, I would invite Dr. N.K. Singh, sir, who is a director of Diabetes and Heart Research Center, Dhanbad. Sir is also a chairman of RSSDI Jharkhand from 2019 till 23, and sir is also an executive member of National RSSDI till date and ex-governing body member of National API,
Yeah,
ex-chairman
Amit, that
API.
will be fine. Every
Yes,
month they are hearing me.
yeah,
So,
yeah,
so yeah. So now I am
yeah,
also the vice president of the RSSDI.
yeah.
Technical team, please give the moderator CV.
Yeah.
So, dear audience, welcome again for a very exciting session today on the diabetic food problem, that is the smart antimicrobial choices in diabetic foot infections, when to use and when, what to use and when. So I think this is a huge problem, and I have seen so many things, so many problems in the selection of antimicrobial choices. So I think you go ahead. I think Dr. Ojha will, yeah. So today one of the moderator is here, Dr. Arvind Kumar Ojha. He is a consultant diabetologist, ILS Hospital, and also now chairman of the IPA from the West Bengal chapter. He is a certificate diabetes care, Newcastle University, Australia, and FICP MD, fellow Diabetes India, and life member of this IPA and other societies. So welcome, Dr. Arvind Kumar Ojha from Kolkata. Yeah, next. Yeah, so really welcome Dr. Hridaynath Lotikar. He is a consultant physician and diabetologist at Galaxy Hospital, Mapusa, Goa. And he is the MBBS from the Vologad State Medical University and certificate course in diabetes from the Chelaram Diabetes Institute and fellowship in ECHO and from Dr. Lotikar's ECHO Center, Mumbai. So he is a registered member with RSSDI, API, Lipid Association of India, and currently he is the secretary of the RSSDI Goa chapter. So welcome, Dr. Hridaynath Lotikar. And
Thank you, sir.
next, then from Jharkhand, I think a remote place, Chaibasa. Welcome, Dr. Soumya Sengupta. He is a director and consultant diabetologist at Dr. Soumya Sengupta Diabetic Clinic, Chaibasa. Senior residency at Kolkata National Medical College, Kolkata, and life member of Jharkhand Diabetic Federation, RSSDI life member of CCDSI, and also he is a life member of the IPA. So I think welcome, Dr. Soumya Sengupta. With that, Dr. Arvind Ojha, I would like or I request you to introduce our today's speaker. So please display the CV. Yeah, Dr. Ojha.
Good evening, friends and colleagues. Thank you, Dr. N.K. Singh, for giving me the opportunity to be in this session. Today's session, our speaker will be Dr. Sandeep Suri. He is a senior diabetologist and consultant physician at Ever Healthy Hospital, Hishar, Haryana. His other credentials are already being displayed. And let's hear Dr. Suri on the interesting topic of choosing antibiotics in diabetic foot infections and how do they smart work. Thank you, Dr. Suri, please.
Thank you, sir. Very good evening, friends. At the outset, I must thank CME India for giving me an opportunity, specifically Dr. N.K. Singh, sir, and all my senior, my friend moderators. Very warm welcome to all of you and great thanks from my side. I'm going to talk about very important aspect of diabetic foot, that is diabetic foot infections. Friends, diabetic foot infections are very frequent, very severe, and most serious complications of diabetes. These are devastating complications of diabetes. They devastate present of the patient. They devastate future of the patient. They are life endangering and life changing complications of diabetes. Enormous initial cost, enormous recurring cost, and loss of financial burden on patient, on society. And there is substantial rates of limb loss. So this is the end result of diabetic foot infections if we are not managing in an appropriate way. There is a simple break in the skin envelope and patient develops a diabetic foot ulcer. This is an earthquake a tsunami in the life of diabetic patients. But why the foot ulcerate? There can be a person at risk with various complications of diabetes, maybe micro and macrovascular complications of diabetes, certain habits like smoking, sometimes sarcopenia, inactivity, both even weight loss, severe weight loss, and also inactivity, all can lead to increased risk of foot ulceration, but predominantly it is peripheral neuropathy. The most common complication of diabetes, most devastating complication of diabetes, peripheral neuropathy, and patient keeps on walking on insensate feet, having lot of injuries, but getting unnoticed. Associated with this, roughly around 20% or 30% of patients will have peripheral artery disease. But along with that, there is a third component, that is foot deformities. And that can be any foot deformity. That foot deformity can be mobile or can be static foot deformity. Patient starts developing calluses at the high pressure points, calluses break down, ulcer gets underneath. There can be other associated conditions like edema, or there is prior amputation and ulceration that alters the biomechanics, and they are also a very high risk for further ulcerations. But why a diabetic foot ulcer doesn't heal? Why it becomes chronic? So there are various reasons. We know that diabetes per se, specifically uncontrolled diabetes, is a immunocompromised state. There are other associated risk factor or factors which leads to further decrease in immune status, hypercholesterolemia, hypertension, hypertriglyceridemia, dysfunctional HDL, and increased vulnerability for cardiovascular risk. They are also associated with unhealing, non-healing diabetic foot ulcer. There is also associated cellular level, or you can say at the level of microcellular level, there are certain changes which leads to non-healing of the wound. Macrophages are not properly working. Lymphocytes, neutrophils, cytokines, and all cytokines which are released, they are not in appropriate way, ultimately leading to a wound which is not healing. There is decreased cellular crosstalk, decrease interaction between the cells, decrease inflammation, decrease proliferation, decrease migration, decrease angiogenesis, decrease uh, 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 extracellular polymetrics formation, and there is unstable or poor remodeling. There is hyperproliferation, there is absence of keratinocyte migration, impaired angiogenesis, and impaired immune cell function. Ultimately, this wound is not going to heal. So what this will lead to? Here is an ulcer, which is an open ulcer with ulcer with a necrotic tissue with lot of inflammation, and that gets infected because bacteria, they are colonizer, they are commensals, but once they start invading the ulcer or invading the tissues underneath, that becomes infection. Initially, it is a monolayer or planktonic bacteria. Then they combine together, multiple bacteria comes together, they form a microcolony. They secrete lot of extracellular polymetrics and they form a biofilm. And this biofilm make them get matured and that get dispersed. And ultimately, this leads to persistent chronic infection, which is not responding to any antibiotic, and that goes deeper and deeper, ultimately involving bones. You call it an osteomyelitis, leading on to consequences of amputations. Foot infections, very common. 60% of lower extremity amputation in subject with diabetes are due to infected foot ulcers. Often they are polymicrobial with aerobic gram-positive and gram-negative organism associated with obligate anaerobes. And all these depends upon the severity of infection. Infections are potential emergency. This last line is very, very important. You can say that within few hours, the whole scenario changes. The patient becomes into limb threatening to life threatening situations. So the things can worsen within days and even hours. So this is very important. We have to be very proactively looking and aggressively treating diabetic foot infections because worsening can happen within few hours. Now, I will be talking about how to manage diabetic foot infections through IWGDF and ITSA guidelines recently published in 2023. And very important highlight is that from tiny cut to lost toe, it is so fast. 20% of diabetic foot infection results in amputation. Once we find a diabetic foot ulcer, and we are talking about diabetic foot infection, there are 4 important questions we have to ask. Whether there is presence of infection, yes or no. What is the severity of infection? If the answer is yes, severity of infections. Number 2. Number 3, how much deep it is and what are the tissues which are involved. And number 4, which is very, very important, look at the vascular status of the foot. So these 4 questions, if you are able to answer on the day 1, you are always on the right track. Remember, diabetic foot infections are one of the part of management of diabetic foot ulcer. It is not you are giving good amount of antibiotics along with culture sensitivity reports, you are doing justice to the patient. No, until unless you follow a proper diabetic foot management guidelines, and they require microbiological control, number 1. Number 2, wound control. Number 3, vascular control. Number 4, offloading or mechanical control. And number 4, metabolic control. So all these 5 components has to be there, and you are not alone. There are more than 20 specialists which are involved in management of diabetic foot ulcer. Coming to the first question, look at the signs of infection, because if there is no sign of infection, no symptom, no antibiotic. So it's a very simple. Diagnose a soft tissue diabetes related infections clinically based on presence of local or systemic signs and symptom of inflammation. I will be talking about them also. If there is mild infection, that means you have got 2 or more than 2 signs of local inflammation, and erythema is very small or less than 2 centimeter, you have to give antibiotics, but that has to be narrow spectrum antibiotics. If there is a grade 3, moderate, erythema more than 2 centimeter or more, there is associated lymphangitis, there is deeper skin infection, there is abscess, there is bone and joint involvement, you call it osteomyelitis, it is grade 3, and that is moderately infected foot. You have to go to further higher or broader spectrum of antibiotics. And if it is severe, patient has got systemic inflammatory response syndrome or systemic toxicity or metabolic decompensation, you are not going to waste even single second. You have to be on broad spectrum antibiotics covering gram positive, gram negative, and anaerobes from day 1 or from the first second. So that is very, very important. Now, what are the indications of infection? How you can talk with the wound? I always say talk with the wound, look at the wound, and then you will be able to know about whether it is infected or not. Redness, pain, tenderness, swelling, warmth, and purulence. These are characteristic markers of inflammation. If there is inflammation, definitely there is chances that leads to indication that it is infected. But diabetes is a great confounder. It's a great confounder. All these can be camouflaged. All these can be hidden. Redness may be marked due to peripheral artery disease. Pain may not be there due to peripheral DSPN. Tenderness may not be there due to DSPN. Swelling may be marked due to peripheral artery disease. Warmth may not be there due to peripheral artery disease. Purulence may not be there. So all these can be negative due to DPN, autonomic neuropathy, vasculopathy, and immunocompromised state. So you have to rely on secondary signs of infection. And these are extremely important points that I'm going to highlight. Each and every point is very, very important. Purulent discharge, serous exudate, fetid odor. You open the bandage or look at the wound, and the whole room is become a very fetid odor. Poor granulation tissue. You touch the granulation tissue, it is very friable. Discolored granulation tissue, not looking healthy pink. Friable granulation tissue. Pocketing of wound base. There is tunneling, there is undermining of edges, there is systemic signs of increased inflammation, and it becomes very painful. Even insensate, painless foot becomes very painful. So that is pain in the previously insensate foot. poorly controlled glycemia, which was there previously, but recently it become uncontrolled and you require higher and higher dose of insulin or upgradation of your oral antidiabetic drugs. Systemic signs of inflammation also, undermining of edges, tunneling, sinus tract formation, and deeper tissues are being involved. So that clearly indicates these are severe signs of infection, secondary signs of infection, and never to miss all these. Then there are various questions regarding biofilms. I told you initially it's a planktonic bacteria which are freely mobile, which are excessively dividing also, and they just becomes a colony formation happens, and there is increased amount of extracellular polymatrix formation, and that's make a sheath which is nutrient laden, and that is avoiding the penetration of antibiotics, and bacteria keep on growing under that sheet, and that is known as biofilm. Most of us think that there are slimy layer on the ulcer is a biofilm. Friends, it is may or it may not be, because biofilms are microscopic things. They may be deeper inside. So how can you think that there is a biofilm formation in the wound? Failure of antibiotic treatment or recurrence of infection, particularly if the evidence is provided that same organism is repeatedly growing. Then if there is any medical history of biofilm predisposing condition, like then there is implanted medical device, or there is evidence of multiple or recurrent clinical infection in the same ulcer that resolve with antibiotic only to recur after the therapy has been stopped. Prolonged signs, classical signs of inflammation, low-grade inflammation continued even by doing repeated debridement, sending culture, giving antibiotic, still it is not getting cured, it is definitely biofilm. Culture negative results despite optimal sampling technique and a high suspicion of infection by clinician, you are dealing with a biofilm. Secondary or covert signs of infection such as friable granulation tissue or undermining or tunneling, and there is involvement of bone or osteomyelitis, definitely you are dealing with a biofilms. Now coming to how to classify these infections. There are various classifications right from Wagner, PDs or University of Texas. There are various classifications, but there are two classifications which are basically favored by IWGDF. Most validated classifications are by Sinbad and Wi-Fi classification. Sinbad classification looks at site of infection, involvement of ulcer, it may be forefoot or midfoot, ischemia, neuropathy, bacterial infection, none or present, ulcer area less than 1 centimeter square or more than 1 centimeter square, depth of ulcer, and possible score is 6. So this is Sinbad infection a classification, but more important is Wi-Fi classification. Wound, inflammation, or a wound, ischemia, and infection. So this is the way to have a proper comprehensive classification. Wound, whether there is ulcer, deep ulcer, shallow ulcer, bone involvement, inside tissues, or there is gangrene, what is the type of exudate, all these are comprehensively looked at various grades. Similarly, ischemia, depending upon ankle brachial index or ankle systolic pressure or TCPO2, and also toe pressure, they are all being a very important part and parcel of management of diabetic foot ulcer and infection, and that also prognosticate your patient, which type of patient the ulcer is going to heal, or it can be progressive, or it can lead to gangrene, or it is being requiring of amputation. So all these things can be very comprehensively looked at by looking for Wi-Fi classification. You have to look for wound, ischemia, and foot infection. Regarding foot infection, if there is no symptoms or signs of infection, you call it non-infected. If it is present in or signs are present like local swelling, erythema, all these things which I have just enumerated in detail, they make it a foot infection, maybe grade 1, grade 2, grade 3. But importantly, this is the one test which can be giving, which it is a very excellent bedside tool, highly sensitive, very specific for underlying osteomyelitis. This is probe to bone test. If there is a gritty feeling at the probe, which is sterilized probe, along the margins of the ulcer, in the center of ulcer, if you just poke it, Slowly, if you try to maneuver it, touching the bone, it is nearly 95 to 100% indicative of your osteomyelitis. But remember never to forget about all these life-threatening conditions or life-threatening situations. It can be limb-threatening to life-threatening situations within few hours. If there is objective evidence of new altered mental status, or there is respiratory difficulty, saturation going down, heart rate increasing, systolic blood pressure going down, urine output going down, all of you are aware of all these things, but these are very practical tools, very practical criterias looking for life-threatening, life-endangering conditions. Patient has to be admitted in ICU and it requires broad spectrum antibiotic covering everything. Now, you are looking at the wound and the ulcer is in front of you and you have diagnosed that this ulcer has got infection by looking at the clinical signs. So the thing is that you have to send the culture sensitivity. You have to send the culture. So in a person with suspected soft tissue diabetic foot infection, consider a sample for culture. But first you have to debride, you have to clean. After debridement and cleanification, you have to take the deep tissue culture, because only then you will be able to know the invader, or you will be able to know the causative microorganism. Otherwise, if you simple send a swab, you will be getting only commensals or colonizers, and lot of bacteria will come into the picture, and you will be thinking which is the invader out of that. So preferably by accepting, collecting a tissue specimen, by after doing curettage, take a biopsy from the wound. This is the most important message that I just want to tell you. But you can also go with a gram staining. Gram staining is a very handy tool in front of you. By going with a gram stain, you can find a gram positive bacteria which are dark blue color, gram negative bacteria which are stained pink color, and diabetic foot tissue will be staining light blue. So ultimately, you will be able to know that you are dealing with predominantly gram positive, gram negative, or a polymicrobial infection. Now, coming to diabetic foot or osteomyelitis. In a person with diabetic foot osteomyelitis, there is always a question whether we should take a bone sample or a peribone tissue is also effective for sending for culture sensitivity. So, if you are suspecting osteomyelitis of the foot, before or after treatment, after debridement of the area, consider obtaining bone rather than the soft tissue. But peribone tissue is also important. That also gives you good indication, but better to have a bone piece, bone chips for sending for the culture sensitivity. That will give you the exact diagnosis of the causative organism, and you will be able to know about the pathogen and sensitivity of the organism. Now, before culture sensitivity will take some time, okay, it will take 2 days or 4 days, but you have to start the empirical antibiotics. So if there is milder infection, so here I am not going to give you any name of the antibiotics. Basically, names of antibiotics are not to be required. It is the fundamental pharmacology or the fundamental classification of antibiotics that is important, where to use, which type of antibiotics we should use. Predominantly, if it is mild infection, gram-positive cocci are the predominant lesions, organism like Staph aureus coagulase positive or beta hemolytic streptococcus most commonly. And if there is mild infection, there is no need to send for culture. No need, until unless you are doing some sort of research, no need to send for culture. Right with the gram-positive cocci, start with the narrow spectrum antibiotics, take care, cloxacillin, ampiclox, or you can start with clindamycin, doxycycline, or even ceftriaxone. That will be effective. If there is beta-lactam allergy, gram-positive cocci, then you have to go to clindamycin. That will also take care of some amount of anaerobes, but predominantly it is milder, so clindamycin. Quinolones are very good here. Cotrimoxazole, doxycycline, they are all equally effective drugs. Recent antibiotic use, that means within 1 month, there is some antibiotic use for some infection somewhere, some lung infection, some throat infection, some boil, some trunculosis, some sty somewhere. So recent antibiotic use, at least say 1 month, look for gram-positive cocci, gram-negative rods can be there. So here you can suspect some amount of resistance. But still, if the infection is mild, you can go with moxiclav or fluoroquinolones and doxycycline. If there is high risk of MRSA, I will be talking about MRSA at the end. So just leaving at MRSA, but giving you some antibiotics which are there for MRSA. There is lot of hue and cry about MRSA, but situation is not that grim in India specifically. Linezolide, cotrimoxazole, fluoroquinolones, clindamycin, doxycycline, all they are recommended for MRSA. But when to think about MRSA, I will let you know. Now, if there is moderate or severe infection, there is no time to be wasted. No time to be wasted. Directly, you have to start with empirical antibiotics covering gram positive, gram negative, and if there is a deeper infection or there is vascularity involved, deep tissue infections, go for anaerobic coverage also. But if you are using gram positive, gram negative coverage for them, beta-lactam plus beta-lactamase inhibitor like piperacillin, tazobactam, piperacillin, that is equivalent, that is good amount of antibiotic, give in an appropriate dose by giving IV dosage and give it in infusion if you are using piperacillin tazobactam, and that is to be dose is 4.5 gram and IV 8 hourly, and that has to be given in infusion for at least 2 hour infusion has to be there. Beta lactamase inhibitor, they, if you are using BLI like cloxacillin or like clavulonate or ticarcillin, or if you are using selbactam or 5% or tazobactam, these are all BLI, tazobactam, clavulonate, and selbactam. They have got their own anaerobic coverage also. So no need to give anaerobic coverage when you are using BL plus BLI. Otherwise, if you are using second and third generation cephalosporins, you have to use something for anaerobic coverage also, and that is if you are using clindamycin, no need to give anaerobic coverage along with that because clinda itself cover for the anaerobic bacteria. If there is maceration or ulcer, which is macerated ulcer, or there is a warm climate and most of maceration or there is more wet bandages has been used, you can think over pseudomonas. For that, you have to take care of ceftazidime, quinolones, or even carbamazepine or meropenem or imipenem can be used here. Even BLI is also effective in pseudomonas patients. Ischemic or necrosis, if there is gangrene or ischemia, then again you have to take care of GPC, GNR plus strict anaerobes has to be taken care. And here you can go even if you more broader spectrum antibiotics, even taking care of imipenem, meropenem also. Along with that, you have to take care of the anaerobic bacteria, and also you have to take care of the gram-positive bacteria in the form of linezolide or clindamycin that can take care of, clinda can take care of your anaerobes also, and good amount of GPC coverage along with MRSA also. If you're talking about MRSA, again, I have told you these are the antibiotics which can be given. And if you are talking about the resistance to ESBL or gram-negative bacteria with extended spectrum beta-lactamase resistance, then carbapenem or meropenem, imipenem, quinolones, they will be effective, and even aminoglycosides. But in diabetic patient, there has to be a certain rules to be followed. The dosage of antibiotics have to be altered because the patient may be in heart failure, patient may be requiring CK or they may be having altered GFR. Even the pharmacokinetics of the drugs can get altered in patient with diabetes. So all these things you have to review. You have to look at the dosage, and most of the time, moderate to severe infection, you have to give IV dosage and patient has to be hospitalized. Now, administer antibiotic to a patient with a skin or soft tissue infection or diabetic foot infection only for 1 to 2 weeks. Don't keep on giving unnecessary duration of antibiotic. Nothing required. 1 to 2 weeks. Consider continuing antibiotic if there is slow healing or there is some vascularity is involved. You can continue even up to 3 to 4 weeks. But traditionally, it is 1 or 2 weeks of antibiotic that is more required. So this point is very important. Provide the patient with a date of end of the antibiotic, that I'm going to end antibiotic within 2 weeks, within 1 week, within 3 weeks, because this is not the date of complete wound healing, which may be requiring for 6 weeks to 12 weeks. So you are treating an infection. The healing will not be there without treating infection. But infection treatment doesn't mean that wound has healed. So consider antibiotic duration for up to 3 weeks after minor amputation of diabetes-related osteomyelitis if you have removed the bone. But if you are taking care of the bone itself and you have just curettage and bone is still remaining, you can continue antibiotic for 1.5 months also. So that is without bone resection, you can still save the limb or still save the toe for continuing for up to 6 weeks. Now coming to certain big questions. If we are talking about extended spectrum beta lactamase inhibitor, beta lactamase is there, ESPR is there, what to do? All penicillins, second and third generation cephalosporins will not work. Astronam should be reported at the resistance. So they will not be working. So what will be working? It will be BLI or second or third generation cephalosporins, they will be working. Now, ESBL happens by two ways. One is plasmid driven, that is TAMS1, TAM2, SHV1, SHV2, they are all plasmid driven, or it is chromosomal mediated, where you can have AMP-C or metallobictalactamase positive. So this is the basic microbiology knowledge. So if you are having TAM1, SHV, ESBL, what will be working for you? The carbapenems will be working for you, like imipenem, meropenem, that will be working for you. TG cycline will be working for you, specifically if you're talking about Klebsiella. If monobactam and carbapenem, both, they will be working, but higher, if you go down, if there is AMP-C, BLI, or if your 5% azobactam will not be working for you. What will be working? Maybe cefepime will be working, maybe carbapenem will be working. But if there is metallo-beta-lactamase positive or extended ESBL, all above antibiotics plus carbapenems will be resistant. So you will be relying on very question mark, either on aztreonam, colistin, or EDTA related some molecules like ceftriaxone with EDTA, cefepime with EDTA, or tigecycline, they may be helpful to you. So in a patient who has got AMP-C producer, ceftriaxone resistance will be quoted to you. So here, nothing like clavulanic acid, tazobactam, sulbactam, all BLI will not be effective. All BLI will not be effective. What will be effective? Maybe carbapenems, or you will be requiring aztreonam, colistin, TG cycline. That will be only requirement here. Now, coming to MRSA, when should we think about, first, when should you think about ESPL? The patient who has got deeper tissue involvement, number one. Number two, the patient which has got peripheral artery disease or microvascular dysfunction. Number three, the patient who has got recurrent infections. There you should think about ESBL formation, or you're talking about biofilm formation. There you should think of ESBL infection. Regarding MRSA, there is a lot of suspicion of MRSA each and everywhere, but remember, MRSA by and large in India in diabetic foot ulcer is not that predominant. If you send 100 culture sensitivity reports, only 15 to 20 will tell you MRSA, 80% it is MSSA. Okay, so don't think MRSA otherwise. But if MRSA you are suspecting, you have to suspect in certain situations the patient who has got recurrent infections, patient who has got already been exposed to antibiotic within 1 month, patients who are carrier of MRSA, or patient who are being hospitalized for other infections, there the chances of MRSA can be there. But if you are given MRSA, which antibiotics will be effective here? The antibiotics which will be effective here will be clindamycin, linezolid, rifampicin, or you can talk about vancomycin, or even macrolides in the form of clarithromycin, but you have to give IV doses of clarithromycin, chlortriamoxazole, they will be effective here. Even your aminoglycosides will be also effective here in the form of amica and gentamicin. And other like cefepime, or they will be also effective here. But many antibiotics will be just not effective here, not to give third generation cephalosporins here, not to give second generation cephalosporins here. So that will further add to the further add to the resistant portfolio. So remember, there can be MRSA, but only in suspected certain conditions. Each and every time, don't think about MRSA. Look at the clinical signs, look at the clinical risk factor for MRSA, only then decide about these things. The antibiotic commandants are 5 important antibiotic commandants. If isolated is ESBL producer, never use penicillin, never use cephalosporins, but you can use third generation cephalosporins with beta-lactam inhibitors only, Sulbactam or clavulanate also. If the isolate is Salmonella shigella, never to use second generation cephalosporin. If isolate is MRSA, never use beta-lactam because that will not be effective. And also if the isolate is Enterococcus, never use cephalosporin because they are indigenously resistant to all these. And very important question, when you look at the culture sensitivity report, what is MIC value? MIC number gives you the lowest concentration of antibiotics, and that will inhibit the growth of bacteria. So how to interpret this MIC value? There is another value which is important, is break point. I will tell you how to interpret MIC and also to look at the break point. Break point is another value where the bacteria starts getting into resistance. So if there is a distance between MIC to break point, higher the distance points, more chances of having effective antibiotics. I will explain. These are the two questions, two pictures in front of you, E. coli strain. Both picture shows, picture one shows it is sensitive to amoxicillin, and another picture shows it is sensitive to cenflexin. MIC of amoxicillin is 2 microgram per ml, whereas cenflexin has got 8 microgram per ml. So both are sensitive. But look at the break point. Break point between amoxicillin to break point, there are 4 steps, 4 points, 4, 8, 16 and 32. So there is a difference of 4 points. Whereas if you look at cenflexin, there is a difference of only 2 points, 16 and 32. So which one is more effective? Very simple answer. Amoxicillin is a more sensitive, more specific, more active drug for this bacteria. Very simple. Look at the difference between MIC and the breakpoint. You will get the answer. So amoxicillin and cenflexin, the breakpoint difference, and that will tell you that beneficial antibiotics for you. If you're talking about vancomycin, we talk about vancomycin for MRSA patients, but with vancomycin, there is certain trick. For vancomycin, you have to ask for specific modalities to check for sensitivity pattern, because disc diffusion pattern will not be effective here. There is vancomycin resistant enterococci, VRE, which are also commonly coming up recently. These VRE are genetically vancomycin resistant, but phenotypically vancomycin sensitive. So on disc diffusion, they will tell you that vancomycin sensitive. But if you go to genetic culture sensitivity techniques, it will tell you that this is resistant to vancomycin. So if you're talking about vancomycin, or there is a vancomycin sensitivity comes into picture, or you are talking about MRSA and looking for a vancomycin, ask your microbiologist colleague to tell you to do specific genetic testing for vancomycin sensitivity. Now coming to a culture sensitivity report, which is routinely seen. Friends, there is no time to look at these type of reports. Always ask for MIC value and breakpoint. If you ask this much, you will get the answer. You will get the answer. Here the report says sensitive to ceftazidime, sensitive to Genta, sensitive to imipinem, sensitive to piperacillin, sensitive to tobramycin, resistant to Cipro. Okay. So if there is any difference between Genta and Tobra, yes, there can be difference in Genta and Tobra. Both are sensitive here. So what can be the difference? You can look at the MIC value. Tobra has got MIC value of 0.5, whereas Genta has MIC value of 4. So that clearly indicates Tobra is much more sensitive for us. Much susceptible bacteria is there with tobramycin. It is 8 times, Genta has got 8 times higher MIC. So why not to go for tobramycin? So MIC value will tell you everything, but if you club with breakpoint, you will get all information. So take home messages from my side. Diabetic foot ulcer could be polymicrobial. Very commonly in Indian scenario, we are having polymicrobial infection, but milder infection still talk about gram-positive cocci. These are Staph aureus, coagulase positive, and beta hemolytic streptococcus. Investigate thoroughly with an open mind without bias. Don't rely on anecdotal evidences. Don't rely on your reflexology. Be scientific, look at the wound, decide about the simple empirical antibiotics. Always have a clinical microbiologist in your team. Use a focused antibiotic therapy, not a broad spectrum every time. You will be hitting yourself. Remember, you are not done yet, and it might come back to you with another infection. So consider all other vascular issues also. Debridement is a key factor that makes your antibiotics effective, that decrease the bacterial overload. So debridement and good vascular supply is the hallmark that gives you better penetration with the antibiotics. MIC, looking at culture sensitivity reports along with breakpoint and MIC will make you much more wiser. So definitely you have to look at your enemies, that is your wound and infection bacteria, and also you have to look at your agents to kill that enemy, and that is your antibiotics. So win a war of infection with a strategy, not with your bias, not with the reflexology. Thank you. And it is the picture say the patient amputation fears more in comparison to death. So patient fears amputation more. So for us, prevention and protection for amputation is a passion, and we have got obsession to prevent all preventable amputations. Thank you.
Yeah, so I think this was a great lecture, sir. Can you stop sharing? Then we can discuss. So, really, it was a mind blowing. Don't think I have heard something like that about this topic. So, Dr. Arvind Ojha, what will be your initial comment on this?
Thank you, Dr. Suri, for a nice presentation. It was a wonderful lecture, and you tried to cover almost everything of a diabetic foot infection. Few things with regard to that I'd like to add is it's very rare to have a single organism present in a wound. So unlike the temperate countries, we usually have polymicrobial, even if it is the infection is mild. This is one point. With regard to biofilm, you said sometimes in spite of biofilm, by nature having multiple organisms, but you said sometimes it can be culture negative.
Yes.
So how to explain that culture negativity in such a biofilm?
Yes, there can be two type of paradoxical situation.
Yes.
Number one is lesion is improving and patient is tolerating your drugs.
Yeah.
But the culture sensitivity tells that the antibiotic which you are using is resistant. So what to do? Lesion is improving, patient is tolerating, counts are coming down, patient is improving, glycemia is settling, and culture sensitivity tells that antibiotic quinolones you are using is resistant. So what to do? Again, here you have to go to again debridement, debride, look at the vascularity, and keep on giving same antibiotic because it is more of clinical response. You are not going to treat that paper report. You have to treat the patient. Again, if you are if as per the properly taken culture sensitivity, you have debrided, cleaned the wound, took the tissue sample, and you took the culture sensitivity report. And with the culture sensitivity report, you are giving appropriate antibiotic. So where is the issue? Still patient is not improving, still the wound is not getting closed, or wound is not healing. So where is the problem? Problem lies into two things. There is a biofilm. You have to ask your surgical colleague, go for deeper debridement. Some bone may be there. You are missing the bone, or some vascularity may be hampered. So you have to ask for tissue Doppler, or you have to ask for ankle brachial index, or go for the vascular Doppler, look at the vascularity. So biofilm always in our mind, but you have to be more clinical. You have to more clinical. The surgical debridement is a key factor that removes the biofilm. And
one more question. Yeah. I would like to, because most of our audience are physicians. And there are certain situations where the physicians found themselves inadequate to handle diabetic foot presentation. So with regard to referral decision, I would like to have you to comment on when to refer the patient immediately, or you can spare some time for the patient like that. Referral decisions are very important for
Yes,
the
yes,
patient.
very, very important, because time is a tissue and time is life also. So
Yes,
here,
yes, yeah.
if you are looking at the limb-threatening infections and you are not tuned for having, or the teamwork is not with you, so you have to refer the patient. If you are looking for, or the patient has got systemic inflammatory response syndrome, SIRS, any factor, fever not subsiding, tachycardia, tachypnea, blood urine output going down, patient is toxic, patient is unstable, refer the patient as early as possible, because that patient requires multi-specialty approach, requires ICU admission. So don't waste the time, even single minute, for that patient. So that is a ambulance situation at that time. So you have to be very close to the patient, very proactively. The things can be managed at your place, very nice. If you have got the issues, please refer your patient as early as possible.
Excellent. So, Dr. Lotikar, your initial comment?
So it was a very nice presentation, sir. Very informative, and a new, like, the way we think. It makes us think more deeper in perspective with the infections involved here. So my main question will be like, you have told with milder infections. Uh, Patients usually come with milder infections, and we see them in the OPD and we write down all the oral antibiotics. So what are the preferred antibiotics orally given? And also just tell me the dosage. So most of the time, like if we give amoxiclav, amoxicillin and clavulanic acid, they confuse with the dose. So it has a shorter half life, so it should be given thrice a day.
8 hours. Yes.
Usually they give twice a day or they give
No.
lesser dose, and
Proper.
they make it little bit confused.
Yes.
So
Always give 8 hourly. Yes, that is.
which should be the preferred dose, and the duration is more important. For how much duration? Because
Yes.
some of them, like, they are giving for 2 weeks, it is still continued, and patient is not like, sometimes they come without any kind of effect. The infections get worsened.
Yes.
They still wait at home until that gets very bad. So what
Yes.
should be the message from us to the patient also, when he should come back and see us?
See, giving antibiotic is a one part of treatment of diabetic foot ulcer infection. You have to go with a mechanical control. You have to go for the metabolic control. So offloading, proper bandaging, proper cleaning, and glycemic control is very important. Even when you are giving good amount of antibiotic at appropriate dose, if we are not following the proper principles of diabetic foot management, the wound will not heal. Wound will not heal. So this is one part of management of diabetic foot ulcer, infection part. Other part has to be there in all pillars have to be there. Otherwise, it will fail. Number one. Number two, the dosage of antibiotic has to be appropriate. That means 8 hourly moxiclav has to be given, 625 8 hourly, that has to be given. Cefuroxime 500 milligram BID dose has to be given, or you are using ciproflox, it has to be given 500 milligram BID dose. If you are using Amsin or Moxiflox, OD dose. Levoflox again OD dose, Lanuzolid 600 milligram BID dose. But remember, duration of antibiotic is again very important. Unnecessary giving duration, longer duration of antibiotics is not going to give you any benefit. What we think, we are going to sterilize the wound. No, it will never happen. It has to be 1 week or 2 weeks, not more than that. And the clinical scenario has to be taken. If there are suspected, just like you are treating tubercular patient or ATT patient, sometimes we go to 6-month therapy, sometimes we go to 9-month therapy. There can be delayed response. There can be slow responders also. So you can prolong the therapy for 3 weeks, but that has to be specifically documented why we are prolonging the therapy. Okay. Otherwise, usually 1 to 2 weeks of therapy is more than enough. More than enough. Even when you are removed the bone, 3-week therapy is more than enough. Not more than that is required. Only when
Yeah.
the bone is there, bone is remaining there, you can go up to 6 weeks. But prolonged therapy of antibiotic is absolutely not required. More toxicity, more drug-related side effect, like linezolid has got a lot many side effects. It can increase your peripheral neuropathy. It can lead to decreased platelet count, and also it can interact with certain drugs like 5-HT drugs. It can interact with Redman syndrome. It is also very commonly seen. Sometimes you are prescribing drugs for peripheral neuropathy like pregabalin and nortriptyline has got interaction with linezolid. Your patient will come to you with serotonin syndrome. Lot of diarrhea will be there, and you will not be able to pick up why this has happened. So, and similarly, Dalacin or clindamycin has got side effects also. They altered your commensals, they altered your gut microbiota also. So, we have to teach all our healthcare physician nothing to prolonged antibiotic. It is 1 to 2 weeks, not more than that.
With
Exactly, sir.
regard
So,
to,
yeah.
yeah, if there is CKD and even if the mild infection, in presence of CKD, it should be treated as severe infection, please. So CKD with
Absolutely.
mild diabetic foot infection should be treated as severe infection.
Yes.
With regard to quinolones, Dr. Suri, I am very fearful about it because this causes a lot of dysglycemia.
Yes.
In some patient, it causes hyperglycemia, in other it causes hypoglycemia.
Yes.
So I am very skeptical about using quinolones. If I use, I only use ciprofloxacin.
Right.
And moxifloxacin has got role only in the lung infection.
Yes.
Diabetic foot infection, it hardly works. So what is your opinion?
Yes, absolutely. For me, it's more favorite is ciproflox. Secondly, levoflox, not more. Moxie, definitely it has got more role with the lung infection. Absolutely.
Dr. Singh, you
Yeah,
were telling
Soumya.
some.
Yeah. Soumya,
Sir.
your initial comment and see what are the chat box questions, and if it is not answered, then you let us know.
Sir,
So,
first of all, thank you, Dr. Suri. It's a brilliant and very lucid presentation. Especially interesting part was that MIC value as well as the break point, which most of the clinicians, I don't think, basically this is a specialty of the microbiologists,
Yes.
you enlightened all. Thank you so much, sir. And in casing, sir, I think then the chat box that the questions has been all the thing has been answered in the discussion.
all answered.
Yes, sir. As sir, I basically work in a primary care setup with very limited resources. So I would like to highlight few points. Though you have already discussed everything, there are some avoidance of common primary care mistakes. Treating uninfected ulcers, overuse of fluoroquinolones, as you said already, and broad spectrum antibiotics, not checking for ischemia, not debriding, stopping antibiotics too early, and not addressing glycemic control. Prioritize adjunctive measures, which is sometimes more important than antibiotics. Sometimes sharp debridement, saline dressings, avoid fancy products are now very much available in the market, and of course offloading, and of course rest, glycemic control, and education at the food hygiene, that is educational control. And lastly, develop a primary care algorithm, whether it is infected or not. As you already said, that Wi-Fi classification is most validated and very easy to follow. Severity, that is mild, moderate, and severe. Check for ischemia. Choose smart empirical therapy. Provide adjunct care. Reassess in 48 to 72 hours. Refer when red flags are present.
Excellent, Soumya. So I think yeah, all the 11 questions have been answered by Dr. Suri
Yes.
presentation itself. So we are not going to deal again. So I think we have got 5 minutes left. So Dr. Lotikar, what is your the take-home message from this topic?
Want to comment one thing.
Yeah.
Uh, as Dr. Suri said, like early infections they come with. So, is there a difference between cellulitis and diabetic foot as an early infection, or should we treat the cellulitis like diabetic foot? I think it's almost the same thing,
Yes,
right?
yes, absolutely same. This is skin soft tissue infection, cellulitis. But in cellulitis, uh, there is erythema and there is no margin. Erysipelas has got some margin, and that is more of bacterial. Cellulitis can be bacterial, it can be even polymicrobial also, and it can be even deeper also. So cellulitis is more dangerous, more dangerous. And you have to see the certain signs if there is any blister formation in the cellulitis. If there is a pain which is extensive to cellulitis, that means cellulitis area is 2 centimeter square, but the pain extends above the cellulitis area, say 3-4 centimeter, or there is associated lymphangitis. Okay, and if there is a blister formation or there is any altered color, that clearly indicate you are not simple dealing with cellulitis, it is deeper inside, it may be necrotizing fasciitis. So never think cellulitis is a simple thing you can manage at least. No, it has to follow same protocol for just like management of hepatic.
So they do this magnesium sulfate glycerin bandage,
Yes,
then
yes,
they just forget about it. So
yes.
they don't assess
Sumac,
it.
sumac dressing, they do sumac dressing that decreases edema. But patient has to be in front of you. You have to keep on looking at the patient daily. Every time you have to see the bandage. Sometimes it works, but sometimes it becomes very dangerous. It goes inside, it leads to more maceration, secondary infection, and necrotizing fasciitis is precipitated. So it's a very simple. The physician should be the captain of the team. Don't leave it to the surgeons or orthopedicians because they may take it very easy. And they are managing burns wound, they are managing deeper wound, bigger wound. That means diabetic foot wound will heal, or it's a simple thing to treat, but that is not simple. They basically that is more devastating.
Dr. Suri, have you used or read something about the uses of rifampicin in the
Yes.
diabetic?
Sir, rifampicin usage is now coming up in a big way. Initially, it was big no to rifampicin, but recently there are certain papers by Armstrong et al. They are now looking for rifampicin as a very good molecule taking care of MRSA. But still, I have never used it, and because of so much predominant tuberculosis with us, and I'm very skeptical in using rifampicin, but it's definitely very effective for gram-positive bacteria, Staph aureus.
From our institute, Dr. Goel has a publication on rifampicin.
Yes, there are publications definitely there.
Yes. And what about the fungal growth in the diabetes?
Yeah, fungal growth definitely that can be there, and maceration and fungal growth can be there. And if there is positive or candida or yeast is positive, then you can add uh, antifungal also. But if you are debriding in a proper way, probably that is not the cause. But sometimes the web space fungal infection and there is maceration and the wound goes inside and there is deeper abscess. So you have to treat in both. So you have to treat with proper antibiotic, debridement, removal of the abscess, and the dead necrotic tissue and antifungal also.
Excellent. So, Dr. Lotikar, one liner message for the audience.
Sir, for the audience, one liner will be like early prevention of infection will help you recover fast. The earlier you treat it, the faster you will recover.
Excellent. Soumya, your take-home message?
Sir, exactly Dr. Lotika said, this is totally preventable.
Yes.
So educational control I give is utmost of important. Look for every clinician should look for the footwear, which is also very important, which is one of the very neglected part. And which is, I think it's totally preventable.
Yeah, Dr. Oja, your final take-home message?
First of, I can give a one-liner: recognize, then provide relief, and refer timely.
Great. So, Dr. Suri, finally, your take-home message.
Yes. See, antibiotics, we are always crazy about prescribing antibiotics. But infected ulcer, 70% are not infected. Only 30% are infected. So don't make the things more dangerous by prescribing unnecessary antibiotic, longer duration of antibiotics, jumping over to higher antibiotics. And we have seen prescriptions of ceftazidime, meropenem, imipenem, even in a non-infected ulcers. Please don't do it. Be rational and use in appropriate way, in appropriate doses, at appropriate time, in right patient, right doses, right use.
Great, sir. So I think now we are end of our seminar. or webinar. So I think this was a great session today, sir. And I think it will be a really a hit when it will be posted as a recorded link also. So I think these our webinars are at least over 1K always. People are listening, and so I am really thankful to the Dr. Sandeep Suri for the so excellent presentation on this subject. Dr. Oja, for your time and your inputs. Dr. Lotikar has also given his excellent inputs, and also Dr. Soumya is doing good work in the diabetic food. Thank you, Soumya. With that, I will now end the session, and Dr. Amit, can you have a proper vote of thanks?
Yeah. Thank you very much, sir. Dr. N.K. Singh, sir, indeed it was a wonderful presentation and very interesting topic because again, diabetic foot infection and antimicrobial resistance is growing in India, and we need to highlight about all this selection of antimicrobial and management in all the settings. Rightly said in this session, maybe not every time it should be a cost effective, or you need to be able to manage that thing. So again, as usual, rightly said by Dr. N.K. Singh sir, that over 1000 audience have logged in, and it is very well accepted once it has been posted on recorded session as well. Thank you very much. Thank you, Dr. Sandeep sir, Dr. Arvind sir, Dr. Soumya sir, for your moderation and support to the Team USV as well. Thank you. Thank you very much. Have a good night.
Yeah, good night to you all audience. Thank you audience also. Thank you very much for presence. Yeah, thank you all. Thank you. So thank you. Good
Thank
night.
you. Thank you, sir. Thank you. Good night.
Thank you.
Good night.
Good night.